Welcome to Anesthetics Unveiled, where we map how anesthetics work, move through the body, and are applied safely in clinical care. The central brain image ties together four themes you'll hear about: mechanisms of action, pharmacokinetics, clinical applications, and safety protocols, setting the stage for a deeper look at how these elements interact in practice. This slide traces anesthetic history from 19th century pioneers who introduced ether, chloroform, and even cocaine for controlled insensibility, to a transformed surgical landscape with dramatically lower mortality and shifting ethics. Modern efforts build on those breakthroughs through safer drug design, stricter safety standards, and continuous work to speed recovery while minimizing side effects. Here we compare general and local anesthesia by mechanism and selection. General agents induce a reversible coma, affecting the entire central nervous system, while local drugs block sodium channels to numb targeted regions. Choosing between them depends on procedure invasiveness, patient comorbidities, and desired post-operative recovery speed to find the safest, most effective approach. This overview emphasizes key agent features like rapid, titratable hypnosis through inhalation control and the role of blood gas partition coefficients in determining induction and emergence speed. It also highlights balanced general techniques to optimize effects and the importance of preserving hepatic function to reduce metabolism-related toxicity, showing how pharmacology and practice combine for safer anesthesia. When comparing propofol, etomidate, and ketamine, think of hemodynamic profile, analgesia, and practical risks. Propofol offers rapid onset, but dose-related hypotension and minimal analgesia. Etomidate is cardiac stable, but may suppress adrenal function. Ketamine stimulates heart rate and provides strong analgesia, yet carries awareness and psychomimetic risks, so clinical context guides the choice. Local anesthetic selection balances onset, duration, and motor sensory effects. Lidocaine acts fast with short duration, ideal for brief infiltrative procedures. Bupivacaine is slower but long-acting, producing strong motor block for prolonged nerve blocks. Ropivacaine gives an intermediate onset with differential sensory preservation, useful when extending analgesia while keeping motor function for faster recovery. Mechanisms of action differ between general and local agents. General anesthetics potentiate inhibitory GABA-A and glycine receptors while reducing NMDA-mediated excitation, tipping neurons toward hyperpolarization and loss of consciousness. Local anesthetics block voltage-gated sodium channels at peripheral membranes, preventing action potential propagation and therefore nociceptive signaling to targeted regions. Functional imaging shows anesthetic selectivity by disrupting cortical and thalamocortical loops that abolish consciousness, while sparing brainstem autonomic centers that maintain vital functions. This safety margin, supported by imaging data, underlies clinically safe sedation by impairing higher-order integration without compromising essential regulatory systems. Inhalational pharmacokinetics are driven by partial pressure gradients, uptake from alveoli to blood, then brain follows those gradients, and vessel-rich organs equilibrate first. Tissue solubility and cardiac output determine induction speed, while high fat solubility explains late emergence as agents redistribute from adipose stores, accounting for both rapid and delayed recovery patterns. Propofol is rapidly cleared by hepatic conjugation into inactive metabolites, producing a short, context-sensitive half-life that makes it ideal for continuous infusion with predictable recovery. Local anesthetics are metabolized by hepatic amidases or plasma cholinesterases, so hepatic blood flow and patient genotype influence block duration and the risk of systemic toxicity, a key clinical consideration. Critical complications include malignant hyperthermia, a life-threatening hypermetabolic crisis treated urgently with dantrolene, cardiovascular collapse requiring vasopressor support for perfusion, and respiratory depression managed with immediate airway control, Prevention hinges on vigilant monitoring, careful preoperative assessment, and ready access to reversal agents to enable rapid intervention when needed. Wrapping up, safety and protocols rely on continuous monitoring like capnography, pulse oximetry, and processed EEG metrics, combined with analysis and guidance for depth adjustment and early detection of hypoventilation or awareness. Standardizing these metrics across care settings improves consistency, speeds response to complications, and supports better patient outcomes.